Hello guys, I am Vishnu. So today I am going to talk about drug-induced liver disorders. So this presentation is divided into individual segments. So here we are going to talk about a brief introduction into some very essential concepts that you need to know about drug-induced liver disorders. Anyways, for anyone who is interested in learning about how drugs affect the liver, and also to some extent you may understand important things of the symptoms that we experience in liver disorders and why they happen. Most of the times whenever we learn the clinical manifestations of a disease or the side effect of a medication, we only try to learn the term, but we don't try to understand why that thing is happening. So here I have referred some very interesting facts about some of the manifestations that may happen in liver disorders and why they happen. So this is going to be a brief introduction. In the forthcoming days, we'll talk about which are the different drug-induced liver disorders, what are the manifestations, how is it diagnosed, and what are the common methods of treatment. So as our YouTube channel always explains this in our description and also in every presentation that I make, that you will get books everywhere, you will get notes everywhere, you will get PowerPoints everywhere. But whatever we study theoretically, unless and until we are able to get the proper practical knowledge through clinical practice or clinical exposure, or even if you're not getting clinical exposure, if you are not able to critically analyze or think or interpret things practically, it is always going to be a tough challenge. So I personally believe that you should be working smart rather than working hard only. I know that all of you are working hard, but I believe that you should add a condiment of working smart as well. So I personally believe that this is no commercial, this is no colorful, interesting thing. Only thing is that is going to interest you here is knowledge, and you are going to get practical knowledge at the level best here. So welcome to an ocean of practical knowledge. So if we look at the definition of drug-induced liver disorder, it's very simple. Adverse effects of drugs on the liver leading to hepatotoxicity. Now, when we classify liver failure or if we classify liver disorder, there are three ways in which we can do that. One is a hyperacute stage, one is an acute stage, and one is a subacute stage. So we have some parameters here. So depending on the stage of liver failure that you are suffering from due to medications, you may have individual parameters that can vary depending on the type of liver failure that you are suffering from. So let's go to the first parameter. Transition time from jaundice to encephalopathy. So jaundice means you can understand very well it is a condition of hyperbilirubinemia, in which bilirubin levels will be high in the blood because either the liver is too damaged or the RBCs are breaking down too rapidly, which is called hemolysis, or whatever condition it is. So transition time means time required for a particular thing to get converted into another thing. So the transition time from jaundice to encephalopathy means the time required for the patient to progress from jaundice to encephalopathy. And definitely encephalopathy is a very serious condition, which is life-threatening and requires aggressive treatment. So the transition time for hyperacute liver failure is 0 to 7 days. Acute liver failure is 8 to 28 days. And subacute is 29 to 84 days. Always remember, whenever we talk about an acute condition, it always indicates seriousness. It always refers to something that is very serious and you require rapid action or rapid treatment. Chronic means the progression is slow, but the disease will always be there. So if we talk about chronic obstructive pulmonary disease, that is COPD, it is not exactly acute. It is a chronic disease. So the lung damage keeps on progressing, but it is slow. But if you are talking about acute exacerbation of COPD, so it will be some kind of infection or some triggering factor which has made that COPD symptom worse instantly. So there we require aggressive treatment, short-acting drugs which reduce the severe symptoms or the acute symptoms. So hyperacute, you can understand very well, it is going to be the most serious liver failure. Acute is intermediate, and subacute is a bit more in the backward section. So now we come to cerebral edema. Cerebral edema, the term itself, you can understand, it is a kind of fluid filling in the brain. So we are going to come to all these things in future slides. Why do they actually occur? So simply, we should not learn that cerebral edema happens, encephalopathy happens, renal failure happens, like that we should not study. We should try to understand what is the mechanism behind such occurrences. So cerebral edema is very common in hyperacute and acute liver failure, but it is very rare in subacute. Renal failure occurs very early in hyperacute because it comes at a rapid onset and it is very severe. In acute and subacute, it occurs, but a bit late. Again, it depends on your kidney condition also. It's not necessary that it will happen in everyone. When we talk about ascites, so ascites is actually a fluid-filled bag that occurs in your peritoneal area or the abdominal area. In ascites usually happens very rarely in hyperacute and acute because it is a very slow phenomenon. It doesn't happen so rapidly. So ascites happens very slowly. That's why it is very commonly found with liver cirrhosis because it's a slow process. So ascites is common in subacute. Coagulation disorders, that is clotting problems. So usually in liver disorders, bleeding problems occur. It is also known as coagulopathy. So that is very significant in hyperacute and acute because definitely these are severe conditions. But in subacute, it is moderate. So you must understand that hyperacute occurs the fastest, acute occurs intermediate fast, and subacute is the slowest. Now we come to prognosis. Prognosis means the chances of recovery. How better will you recover from the condition? So when it comes to hyperacute, the chance of prognosis is moderate. In acute and subacute, the prognosis is poor. But it doesn't mean that it will be applicable to all conditions. We have to see a lot of patients' comorbidity, lot of factors, and then come to a common conclusion. This is just a general scenario. Now let's come to an interesting thing. Like in the previous slide, I explained why cerebral edema happens in liver disorder. So this is what I wanted to tell all of you, that whenever we study side effects or whenever we study the symptoms of a particular disease, or whenever we try to study the diagnosis, anyways in PharmD, we are advised, we are not exactly encouraged to learn diagnosis, but I personally believe that diagnosis is important for us. Because if your diagnosis is wrong, definitely the treatment is also going to be wrong. And then pharmacotherapy or pharmacy practice has nothing to do. So why cerebral edema is observed in liver disease? So there are some steps involved. So when there is a liver damage due to a particular medication, there is accumulation of ammonia and glutamine. Now, why ammonia gets accumulated, we'll talk about that later, because the liver has a detoxifying property of detoxifying ammonia into urea, and that is excreted from the body. But when the liver is damaged, the detoxification property doesn't happen, so ammonia stays as it is. Now, when ammonia and glutamate gets accumulated, it leads to three problems. Number one, increased free radical production. Always remember, free radicals, you have studied in cell injury also. Free radicals usually damage the integrity of a cell membrane. That leads to cell death. So that is why we usually focus on having a diet which is rich in antioxidants if you are having liver disease. And definitely the liver also produces an enzyme which is known as glutathione peroxidase, which is a very powerful antioxidant. I'll talk about that when I talk in any future slide about paracetamol poisoning, which targets the liver. Then there is calcium associated mitochondrial injury. So that is also very severe. If you have seen my slide on linezolid, oxazolidinone antibiotics, I have said that if the mitochondria is damaged, it leads to very severe problems. If the mitochondria is damaged, lactic acidosis can happen. If the mitochondria is damaged, you can have neuropathy related problems as well. So mitochondria damage is also serious. And definitely altered glucose metabolism. The reason is that the function of the liver is to increase gluconeogenesis and also glycogenolysis. So you may have studied in biochemistry, glycogenolysis means the breakdown of glycogen. So the end product is going to be glucose. And gluco means glucose, neo means new, genesis means birth. So new glucose birth. So gluconeogenesis means production of glucose. So that is the function of the liver. But when liver is damaged, this doesn't happen. So that is why hypoglycemia is also seen in patients with liver disease. There will also be high levels of brain lactate. So as I already told you, mitochondrial injury will be there. So lactate level also rises. So that actually causes the swelling of astrocytes which are present in the brain. So I hope you have understood from this. Swelling means it indicates edema, inflammation. So when there is inflammation, obviously edema is also commonly seen. There is another factor, that is activation of inflammatory mediators. So when there is an inflammation in any part of the body, that also causes edema. So if there is an action of inflammatory mediators, then that can increase the permeability of blood-brain barrier. So in that condition also vasogenic edema can happen that can lead to cerebral edema. So there are two mechanisms. One is the role of ammonia and glutamate and also the role of inflammatory mediators. Why ascites in liver disorder? So as I said to you in the previous slide, that ascites does not happen rapidly. It happens as a part of a slow process. So ascites means it is a kind of fluid-filled bag or some kind of fluid-filled content that accumulates in the peritoneal area or the lower part of the abdomen. So there is a vein known as portal vein. It is a blood vessel that carries blood from digestive organs to the liver. So when your liver is damaged, pressure increases in the portal vein. So definitely when in a blood vessel, if pressure increases, it means hypertension. So when pressure builds up in the portal vein, it causes portal hypertension. And if portal hypertension occurs, kidney function worsens. So that is also because due to portal hypertension, some of the important blood supplies that feed the kidneys also get damaged. So the kidney function also worsens. And when kidney function worsens, fluid accumulates inside the abdomen. Because I hope you know very well, even if you are having CKD or acute renal failure also, you may have observed this. Edema is very commonly seen because the function of the kidney is to produce urine. But when the kidneys are damaged, urine is not produced. So the waste materials, the fluid is accumulated in the body itself. So when kidney function worsens, the fluid accumulates inside the abdomen, and the fluid accumulation inside the abdomen is known as ascites. So you can understand in this way, when you are having a liver disorder, the portal vein gets damaged, portal hypertension happens. When portal hypertension happens, there is increased pressure on the kidney. So damage happens to the kidney. When the kidney gets damaged, fluid accumulation occurs because the kidneys are not able to eliminate excess fluid from the body. That gets collected inside the abdomen, which results in the formation of ascites. Why encephalopathy in liver disorder? That is why in liver disorder, to some extent, not completely, but to some extent, patients are advised to avoid proteinaceous diet because the normal condition, if you are having a normal condition, the liver usually detoxifies ammonia. So the liver has a function of detoxification. But when the liver is damaged, ammonia accumulates in the blood. And when ammonia accumulates in the blood, it has a tendency to cross the blood-brain barrier, which can cause hepatic encephalopathy. So hepatic encephalopathy is very serious because in that condition, you can have confusion, you can have tremor, you can also plunge into coma if it becomes very serious. So that is why encephalopathy can be seen in liver disorder. And proteinaceous diet means it is rich in amino acids. But obviously, you can take branch chain amino acids. They are good for liver cirrhosis. I'll talk about that later. But otherwise, you should stay away from protein diet as much as possible. So then we come to muscle. So this is actually the next reason. This is also a very interesting reason that I found. Muscle is actually important for extrahepatic ammonia removal. So in some conditions where you are having muscle wasting syndrome, so for example, if you are having muscle dystrophy conditions or any condition where your muscles are getting damaged or chronically damaged or some kind of scenario like that, there is no scope for ammonia removal. So that is also a high risk of encephalopathy. Now from this, we can actually derive a practical knowledge. Muscle wasting usually happens when serum creatinine levels are low, because I hope you know very well. I'll talk about renal function test in future, that creatinine is usually produced by the muscle. So when you are having an amputation or any kind of muscle dystrophy, serum creatinine levels tend to reduce. So if you are having too much low levels of serum creatinine, that can indicate increased ammonia levels because the muscles is not capable for extrahepatic ammonia removal. But this is just a very simple theorem. We can't directly correlate it with a liver disorder, because for that we have to see what is the condition of liver enzymes in the patient, whether the patient is actually having a documented liver injury or risk of liver injury, and also the ammonia level, because that is the most important thing that we need to look into. So these are the two reasons why we can have encephalopathy in liver disorder. Why renal failure in liver disorder? So in liver disorders, there is increased pressure on the portal veins, as I said before, that can lead to portal hypertension. So definitely when there is increased pressure on the portal veins, it damages the kidney because it causes constriction or narrowing of blood vessels that feed the kidneys, that supply blood to the kidneys. Feeding the kidneys means supplying blood to the kidneys. So if the kidneys are not receiving sufficient amount of blood, then definitely organ damage happens. So that can lead to kidney damage as well. And this kidney damage, as I said before, can cause accumulation of fluid in the abdominal area that can cause ascites. Why coagulation problems in liver disorder? So liver actually plays an important role in clotting process, and that is why in majority of patients who are having liver problems, whether it is disease induced or whether it is a drug induced, they usually have bleeding related problems or coagulopathy. Because when the liver is damaged, the following may occur: reduced synthesis of clotting factors. So if clotting factors are not produced properly, then definitely you know what is the opposite of clotting, it is bleeding. And definitely platelets are also damaged. And if platelets are also damaged, you know the side effects of aspirin, clopidogrel, they are antiplatelets. So they cause bleeding as a side effect. Now let's come to the risk factors for hepatotoxicity. So for example, on the left-hand side, you can see the individual risk factors. And on the right-hand side, you can see the specific drugs that can cause liver damage if you are having a particular risk factor. So for example, if you are a female and you are under nitrofurantoin therapy or you are under sulfonamide therapy, it has been seen that it may elevate your liver enzymes. And already if you are having some kind of liver damage, this can further worsen it. So this is also important to know. You can refer Roger Walker for this. There is a table explained there. So these are the individual risk factors and the drugs that may precipitate hepatotoxicity for the particular risk factor. So female gender, nitrofurantoin, it is actually used in urinary tract infections, and sulfonamides are usually antibiotics. And if it is a male gender, then azathioprine, amoxicillin clavulanate has shown to precipitate hepatotoxicity. But again, this is not necessary that it will happen to everyone. We have to look at a lot of factors, the patient's factors, whether the patient is having a risk of that or not. Then when we come to geriatrics, that means old age people above the age of 60 or 65, isoniazid and amoxicillin clavulanate have been shown to cause hepatotoxicity or at least increase the risk of hepatotoxicity. If it is pediatrics, then valproic acid has a very big risk factor, because that is why valproic acid should never be used in pediatrics under the age of 2. There is another reason for it. It causes pancreatitis. And if you are a chronic alcoholic, means you are taking little amount of alcohol for a very long period of time and you are completely addicted to it, in that condition, paracetamol, isoniazid, and methotrexate can be harmful for you because it can precipitate hepatotoxicity. If you are malnourished completely or if you are on fasting, then paracetamol can elevate your liver enzymes. Again, as I'm saying, it is not necessary that you take a single dose of any medicine and suddenly your liver gets damaged. We have to see the dose-dependent effect. We have to see the individual patient's risk factors. What are the other lab parameters? What are the liver enzymes saying for that particular patient? And in pregnancy, isoniazid can cause hepatotoxicity. If a patient is diabetic, then methotrexate has been found to cause hepatotoxicity. In chronic liver disease, methotrexate and niacin. Niacin is actually nicotinic acid. It is the most powerful agent to increase your HDL cholesterol. Actually, whenever we take medicines for cholesterol, we don't directly take a medication to increase the HDL. Although there are statins, there is a medicine like niacin that can actually increase your HDL. HDL should always be increased through lifestyle modifications, like going for morning walks or eating diet which is rich in fiber, gluten-free fiber especially. So niacin is actually a very powerful HDL increasing molecule, but the problem with niacin is that it has a lot of side effects which actually limit its usage. So if you are having chronic liver disease and you are under methotrexate or niacin therapy, then it may precipitate hepatotoxicity in you. If you are suffering from CKD, chronic kidney disease, then allopurinol. Allopurinol is used in the treatment of hyperuricemia or gout. So that may precipitate hepatotoxicity. If you are having HIV infection, dapsone or cotrimoxazole can precipitate hepatotoxicity. Now, this is very interesting, because if you are having HIV infection, HIV usually causes immunosuppression. So you can have all other kinds of infections from outside, which is also known as opportunistic infections. Dapsone is actually used in the treatment of leprosy. So if you are having HIV and leprosy as well, then you have to be careful while using dapsone. Liver enzymes should be monitored. And cotrimoxazole is much more interesting because I have talked about this in antimicrobial drug of choice. This is actually the drug of choice for the treatment of a special kind of pneumonia that frequently happens in HIV infected patients, and that is known as pneumocystis jirovecii pneumonia. The name of the organism is pneumocystis jirovecii. You can see it in our previous videos. So cotrimoxazole is the drug of choice. So if you are having HIV infection and you are having pneumocystis jirovecii, the drug of choice is cotrimoxazole. But then you have to monitor the LFTs as well. If you are having hepatitis B or hepatitis C infection, then antiretroviral agents and antitubercular agents can be dangerous in the sense that it may cause hepatotoxicity. So obviously, this is also a very big it's very difficult to actually make a proper therapeutic plan, because in HIV infections, usually hepatitis infections are also seen, and tuberculosis is very commonly associated with HIV because of severe immunosuppression. So we have to monitor LFTs. And genetic predisposition. So genetic predisposition means, for example, if anybody in your family had a hepatotoxicity due to phenytoin, sulfonamides, or isoniazid, and then if you are getting a particular disease that requires any of these medications, you may also develop hepatotoxicity. This is interesting. So for example, if anybody in your family had an epilepsy, they were under phenytoin therapy and they developed hepatotoxicity. And if you develop an epilepsy or seizure and you are under phenytoin therapy, then the same hepatotoxicity may occur in you. Same applies to sulfonamides and isoniazid as well. Now, when we talk about the types of hepatotoxic reactions, so we have two types. One is the intrinsic drug-induced liver injury, and the other is idiosyncratic drug-induced liver injury. So intrinsic means it is dose dependent. Always somebody asked me how to remember the dose of a medicine because there are so many medicines in the market. This is a very interesting video that I'll describe about it by this Sunday possibly. So there I'll talk about studying dose dependent effects. So that can be interesting. So dose dependent hepatotoxicity occurs in intrinsic, but dose independent happens in idiosyncratic. That is why the name idiosyncratic. Idiosyncratic means we don't have a correct explanation as to why a particular medicine is causing this problem. And that is why idiosyncratic is unpredictable in nature because it is dose independent. So even in normal dose, it can happen. Even in higher dose also, it can happen. We can't exactly predict the nature of occurrence. But intrinsic is usually predictable in nature because it is dose dependent. There is a distinctive liver lesion. Lesion refers to the physiological damage that we observe. But if it is idiosyncratic, variable liver pathology because it is unpredictable. So we can't exactly say what kind of liver damage or what kind of pathological feature we can observe. So this is also a type of classification that you can study, the types of hepatotoxic reactions. So that's it for this introductory part. I hope that it has given you a brief insight into a lot of practical things that I wanted to share. Please do subscribe and share this video to maximum people. It will not only help your exam perspective or your notes perspective, but it will definitely help in your practical knowledge that you definitely deserve to have. If you want the presentations or the slides for this video, then definitely do join our Telegram channel and do contact with us through the Telegram channel. We'll be very happy to serve you with the slides. So thank you so much for viewing this. So see you in the next presentation, part 2 of drug-induced liver disorder. Until then, it's bye.